How is prostate cancer diagnosed? We know that prostate cancer is an uncontrolled growth of prostate cells, and the growth and multiplication of these cells results in high levels of a substance called PSA, or Prostate Specific Antigen, in the blood. Although the higher the PSA, the more likely prostate cancer is present, other factors can make the PSA higher than it should be. Using older forms of diagnosis, if the PSA was between 4 and 10, about 1 in 10 men would have an important or tiger type of prostate cancer, and about 2 or more a less serious or pussycat type of prostate cancer, and 7 no cancer whatsoever. However, several factors can increase the PSA, e.g. a urine infection, ejaculation within 3 days, cycling, or being unable to pass urine, or indeed having a catheter inserted to drain urine, and sometimes an over-rigorous prostate examination by a doctor. Drugs too can reduce the PSA, e.g. finasteride, dutasteride, or steroids. PSA thresholds have been set to indicate who should and who should not be referred for more investigation by urologists, but these are arbitrary to some extent. If the prostate feels irregular, prostate cancer is more likely, but a doctor can examine the back of the prostate only and would not be able to feel the front, where about 20% of prostate cancers arise. We also know that prostate cancer is more likely as men get older, but also in men with a family history of prostate cancer. Similarly, having had a prostate biopsy that did not show cancer means that the chance of finding cancer on a second biopsy is less. It's hard to work out the exact risk, and it's much easier to use a prostate cancer risk calculator. If one searches Google, there are 3 present, and I've shown 1. For example, I put here the characteristics for a man aged 55 years, Caucasian, PSA 2, and a family history of prostate cancer, with a normal feeling prostate and no previous biopsy. The figure shows the results of taking transrectal biopsies. These are the older form of biopsies, and there are problems with these, but let's ignore that for the moment. This shows that 2 in 100 men would have a serious form of prostate cancer, 17 men a low or equivocal risk prostate cancer, and 81 men no cancer. From the picture you can see how risky things are, and it's very helpful when judging if one wants to go forward with further investigation. If the risk is high enough, an enhanced MRI scan or multiparametric MRI is the next best step for many reasons. Multiparametric MRI means that the prostate is looked at in many different ways. This can identify the spatial location of a cancer. Up to a few years ago, it was not possible to do that. Although multiparametric MRI is not perfect, it's pretty good. It can enable us to identify cancers in the front of the prostate which cannot be felt when a doctor places a finger in the back passage and is not reached by transrectal biopsies, i.e. when needles are placed through the back passage. Having identified a target on MRI scan, it is possible to direct the needles to the abnormality using MRI-targeted techniques. Transperineal biopsies, that is, biopsies directed through the skin behind the scrotum directly into the prostate, can reach both the front and the back of the prostate. As the needles pass directly through the skin and not through the rectum, there is no risk of infection, or at least a much reduced risk of infection compared to the transrectal route, and much less chance of bleeding. By fusing the ultrasound and MRI images, it is possible to direct the needles exactly into the correct place, easy to sample in abnormal areas. As a result, one can be confident that the tissue retrieved by the biopsy technique represents the abnormalities in the MRI scan, and probably the most significant lesion likely to affect the outcome of the individual.
If I click to create a call, it will show us.